Welcome to Pediatric Case Review. Today's lecture is a comprehensive case-based review on pediatric bone tumors. This session is designed for general pediatric physicians and covers 15 carefully constructed clinical scenarios exploring clinical presentation, physical examination, pathophysiology, investigations, treatment strategies, complications, and genetic associations. We use radiographs, magnetic resonance imaging, computed tomography, comparison tables, and diagnostic algorithms to build a practical and evidence-based understanding of these important conditions. Let us begin. Case 1. A 14-year-old male presents with progressive right knee pain lasting 3 months. He reports the pain worsens significantly at night. There is mild swelling around the distal right thigh. There is no history of trauma. The pain does not improve with rest or nonsteroidal anti-inflammatory drugs. The child reports limping and difficulty climbing stairs. Based on this clinical scenario, what is the most characteristic symptom suggesting a pediatric bone tumor? Option A. Morning stiffness relieved by activity. Option B. Persistent nocturnal pain unresponsive to nonsteroidal anti-inflammatory drugs. Option C. Pain occurring only during physical activity. Option D. Migratory joint swelling affecting multiple joints. The correct answer is option B. Persistent nocturnal bone pain that awakens the child from sleep. Night pain is a hallmark red flag for pediatric bone tumors. The key red flags in pediatric bone tumors are nocturnal pain that wakes the child from sleep and is not relieved by rest, duration greater than 4 weeks with a persistent progressive course, localized swelling presenting as a firm non-tender mass over bone, failure to respond to nonsteroidal anti-inflammatory drugs or analgesics, and associated systemic symptoms such as fever, weight loss, and fatigue. Osteosarcoma is the most common malignant bone tumor in children. Night pain distinguishes tumor pain from mechanical or activity-related pain. Any child with unexplained musculoskeletal pain lasting more than 4 weeks requires urgent radiographic evaluation. Case 2. A 10-year-old boy is brought to the emergency department after tripping on a flat surface at school. He reports sudden, severe left thigh pain. His parents note he has had a dull, aching pain in that leg for the past 6 weeks, which they attributed to sports activity. X-ray reveals a fracture line through an abnormal appearing area of the mid-femoral shaft. What is the most likely underlying cause of this fracture? Option A. Osteomyelitis. Option B. Growing pains. Option C. Stress fracture. Option D. Pathologic fracture. The correct answer is option D. Pathologic fracture. Bone tumors destroy cortical and trabecular architecture, dramatically reducing structural integrity. Unlike normal fractures, pathologic fractures occur from trivial forces such as a minor fall, routine activity, or even spontaneous loading. Any fracture from minimal trauma in a child should raise immediate suspicion for an underlying osseous neoplasm, especially osteosarcoma or Ewing sarcoma. A fracture line traversing a lytic lesion on a radiograph is pathognomonic for pathologic fracture, and urgent oncologic referral is mandatory. Pathologic fractures signal advanced local tumor destruction. Early imaging and referral prevent delayed diagnosis. A 6-week history of dull, aching pain in the same location before the fracture is a critical clue that this was not a normal traumatic event. Case 3. A 13-year-old boy presents to your clinic with a 6-week history of left knee pain. During physical examination, you palpate a firm, non-mobile mass over the distal femur. The overlying skin appears normal with no erythema or warmth. The mass does not fluctuate with pressure. What is the most concerning physical examination finding in this scenario? Option A. Firm and non-mobile mass. Option B. Overlying erythema. Option C. Fluctuance on palpation. Option D. Warmth over the lesion. The correct answer is option A. Firm and non-mobile mass. A firm, non-mobile mass is the hallmark of malignant bone tumors. Unlike inflammatory conditions such as osteomyelitis, which present with erythema, warmth, fluctuance, and tenderness, malignant lesions are typically hard, fixed, and lack signs of acute inflammation. This distinction is critical for early referral. Key physical examination clues include a firm non-mobile mass, which is highly suspicious for malignancy, focal bone tenderness suggesting underlying osseous pathology, limping or weight-bearing difficulty indicating structural bone compromise, limb shortening or deformity from tumor-induced structural weakening, neurological deficit, such as foot drop suggesting spinal or pelvic tumor involvement, and absent distal pulses suggesting possible vascular compromise. No single finding is diagnostic alone. The combination of persistent pain, fixed mass, and functional impairment demands urgent imaging and oncology referral. Case 4. A 13-year-old boy presents with a 2-month history of progressively worsening left hip pain and limping. His parents report that he has recently been complaining of numbness and tingling in his left foot. Imaging reveals a large tumor mass in the proximal femur. On examination, he appears uncomfortable at rest and refuses to bear weight on the left leg. What is the priority examination step in this patient? Option A, visual acuity testing. Option B, hearing and audiometric assessment. Option C, neurovascular assessment of the lower limb. Option D, abdominal palpation and organomegaly check. The correct answer is option C, perform a thorough neurovascular assessment of the affected limb. In pediatric bone tumors affecting the lower limb, neurovascular compromise is a critical and time-sensitive concern. Tumors in the proximal femur, pelvis, or popliteal region can compress major nerves and vessels, leading to permanent deficits if undetected. The 5-step neurovascular assessment includes Step 1 inspection to observe limb color, swelling, deformity, and skin changes. Step 2 palpation of pulses including dorsalis pedis, posterior tibial, and popliteal arteries. Step 3 assessment of capillary refill by pressing the nail bed, with normal refill under 2 seconds. Step 4 motor testing including dorsiflexion, plantar flexion, and hip abduction strength. Step 5 sensory testing using light touch and pinprick along dermatomal distribution. Always assess neurovascular status before and after any intervention in a child with a suspected bone tumor. Early detection of compromise can prevent permanent disability. Case 5. A 13-year-old boy presents with a 2-month history of progressive pain and swelling around his right knee. His parents note the pain is worse at night and does not respond to ibuprofen. Plain radiograph of the distal femur reveals an ill-defined lytic lesion with cortical destruction and a sunburst periosteal reaction. The orthopedic oncologist proceeds with a core needle biopsy of the lesion. On histopathological examination, which of the following findings would be most characteristic of this tumor? Option A, small blue round cells. Option B, malignant osteoid production. Option C, cartilage matrix with capping. Option D, storiform spindle cell pattern. The correct answer is option B, malignant osteoid production. Osteosarcoma originates from primitive mesenchymal cells that aberrantly differentiate into osteoblasts, leading to malignant osteoid matrix production. Key pathological features include location in metaphyseal regions of long bones, peak age during the adolescent growth spurt between 10 and 20 years, mechanism driven by accelerated bone remodeling leading to tumorigenesis, and histology showing pleomorphic spindle cells with direct osteoid formation. The sunburst periosteal reaction on X-ray reflects rapid tumor growth breaking through the cortex and lifting the periosteum. Small blue round cells are the hallmark of Ewing sarcoma, not osteosarcoma. The aggressive nature of osteosarcoma is amplified by early hematogenous spread, primarily to the lungs, and pathological fracture risk through cortical destruction. Case 6. A 13-year-old boy presents with a 7-week history of dull, aching pain in the midshaft of the right femur. He reports intermittent low-grade fever and fatigue over the past month. Plain radiograph reveals a permeative lytic lesion with an onion skin periosteal reaction in the diaphysis. Magnetic resonance imaging confirms a large soft tissue mass with medullary invasion. Pathology shows small round blue cells on biopsy. Which chromosomal translocation is most characteristically associated with this tumor? Option A, T9, 22, Q34, Q11. Option B, T15, 17, Q22, Q12. Option C, T12, 21, P13, Q22. Option D, T11, 22, Q24, Q12. The correct answer is option D, T11, 22, Q24, Q12. This translocation results in the EWSR1 FLI1 fusion gene, the molecular hallmark of Ewing sarcoma. The EWSR1 gene on chromosome 22 fuses with the FLI1 gene on chromosome 11. The resulting EWSR1 FLI1 fusion protein drives uncontrolled cell proliferation and blocks normal differentiation, resulting in rapid growth, soft tissue invasion, and early metastatic spread to lungs and bones. This fusion is detected in approximately 85% of Ewing sarcoma cases and is confirmed by fluorescence in situ hybridization or reverse transcription polymerase chain reaction on tumor biopsy tissue. Comparing osteosarcoma and Ewing sarcoma, osteosarcoma arises from osteoblastic mesenchymal cells with TP53 and RB1 mutations, shows pleomorphic spindle cells plus osteoid on histology and a sunburst or Codman triangle periosteal reaction. Ewing sarcoma arises from undifferentiated mesenchymal stem cells with the T11, 22, EWSR1, FLI1 fusion, shows small round blue cells on histology and an onion skin or hair-on-end periosteal reaction. Case 7. A 10-year-old boy presents with a 7-week history of persistent right leg pain, worse with activity and partially at night. His mother reports a visible swelling just below the right knee. He is otherwise healthy with no fever or weight loss. On examination, there is a firm, non-tender swelling over the proximal tibia with no overlying erythema. What is the most appropriate first investigation in this child? Option A. Plain radiography of the affected limb. Option B. Serum lactate dehydrogenase level. Option C. Whole body positron emission tomography and computed tomography scan. Option D. Bone marrow aspirate and trephine biopsy. The correct answer is Option A. Plain radiography of the affected limb. Plain radiography is the first-line imaging modality for any suspected bone tumor. It is the most accessible and cost-effective imaging tool available in any clinical setting. It detects key periosteal reactions, which are the first visible sign of aggressive bone pathology. It guides next imaging steps by determining whether magnetic resonance imaging, computed tomography, or biopsy is warranted. It provides lesion characterization including location, borders, matrix, and cortical involvement. Radiographic patterns to recognize include sunburst pattern and Codman triangle for osteosarcoma and onion skin or hair-on-end pattern for Ewing sarcoma. Osteosarcoma shows moth-eaten bone destruction with present osteoid calcification. Ewing sarcoma shows moth-eaten destruction with absent calcification and frequent large soft tissue masses. Any child with unexplained bone pain lasting more than 4 weeks should receive a plain radiograph before any other investigation. Case 8. A 13-year-old boy presents with a 2-month history of progressive right thigh pain and a firm, non-tender mass near the proximal femur. Plain radiographs show an aggressive lytic lesion with cortical destruction. The orthopedic oncologist now needs to determine the full extent of local tumor spread, soft tissue involvement, and proximity to neurovascular structures before planning surgery. What is the best imaging modality to assess local staging and soft tissue extension in this patient? Option A. Ultrasound. Option B. Computed tomography. Option C. Magnetic resonance imaging. Option D. Bone scintigraphy. The correct answer is Option C. Magnetic resonance imaging. Magnetic resonance imaging is the gold standard for local tumor staging in pediatric bone tumors. It precisely delineates intramedullary tumor extent, which is critical for surgical margin planning. Skip lesions, meaning separate metastatic foci within the same bone, are only reliably detected on magnetic resonance imaging and are missed by X-ray and computed tomography. Superior contrast resolution reveals tumor encroachment on vessels, nerves, and adjacent joints. It determines if the tumor crosses the growth plate, which is essential in skeletally immature patients. Comparing imaging modalities for medullary extent, skip lesions, and soft tissue assessment. X-ray has limited medullary detection, misses skip lesions, and is poor for soft tissue. Computed tomography is moderate for medullary extent, partially detects skip lesions, and is good for soft tissue. Magnetic resonance imaging is excellent for all 3 categories. Magnetic resonance imaging must include the entire bone with both adjacent joints using T1 post-contrast fat-suppressed sequences for complete tumor delineation. Case 9. A 13-year-old boy is diagnosed with a suspected malignant bone tumor of the proximal tibia following magnetic resonance imaging and plain radiographs. The Pediatric Orthopedic Oncology team is planning the diagnostic biopsy. Which of the following represents the most critical principle when performing a biopsy for a suspected pediatric bone tumor? Option A. Always perform excisional biopsy to remove the entire lesion at once. Option B. Ensure that the biopsy tract is completely resectable during definitive surgery. Option C. Perform biopsy before obtaining any imaging studies. Option D. Use horizontal incisions on the limb for easier wound closure. The correct answer is Option B. Ensure the biopsy tract is completely resectable during definitive surgery. The biopsy tract is considered contaminated tissue and must be excised together as one block during definitive resection to prevent local tumor spread. Percutaneous core needle biopsy is the preferred technique because it has lower morbidity, a smaller contamination zone, and provides sufficient tissue for diagnosis. Excisional biopsy is contraindicated because it risks widespread contamination and may force amputation instead of limb salvage. Biopsy must be performed after all imaging including X-ray, magnetic resonance imaging, and computed tomography is complete. Site selection must be planned by the treating surgeon, not a general radiologist, to align with the eventual surgical approach. The diagnostic workup algorithm follows this sequence: suspicious bone lesion, then plain radiograph, then advanced imaging, then referral to orthopedic oncology center, then image-guided core needle biopsy with a resectable tract, then histopathology plus molecular markers for definitive diagnosis. An incorrectly placed biopsy can convert a limb-salvageable tumor into one requiring amputation. Always refer to a pediatric musculoskeletal oncology center before biopsy. Case 10. A 13-year-old male presents with 4 months of progressive right knee pain, worse at night, not responding to analgesics. No history of trauma. Examination reveals a firm, tender, non-mobile mass over the distal right femur with mild swelling. Full neurovascular status is intact. X-ray reveals an ill-defined lytic lesion with a classic sunburst periosteal reaction at the distal femur metaphysis. Magnetic resonance imaging confirms intramedullary extension without cortical breach and no skip lesions. Chest computed tomography shows no pulmonary metastases at this time. Biopsy confirms high-grade osteosarcoma with direct osteoid production. What is the most appropriate systemic treatment strategy to address micrometastatic disease before definitive surgery? Option A. Targeted immunotherapy as primary systemic treatment. Option B. Isolated radiotherapy to the primary tumor site. Option C. Hormone therapy to suppress bone remodeling. Option D. Neoadjuvant chemotherapy before surgical resection. The correct answer is Option D. Neoadjuvant chemotherapy before surgical resection using the MAP regimen. In severe osteosarcoma, acute joint bleeds require immediate restoration of factor VIII activity. The MAP regimen consists of 3 agents. M stands for high-dose methotrexate, which is a folate antagonist that inhibits DNA synthesis and is administered with leucovorin rescue. A stands for doxorubicin, also called adriamycin, which is an anthracycline antibiotic that intercalates DNA, with monitoring required for cardiotoxicity. P stands for cisplatin, which is a platinum-based agent that cross-links DNA strands, with monitoring required for nephrotoxicity and ototoxicity. The goal is to eradicate micrometastatic disease before surgery and assess tumor chemosensitivity. After resection, the pathologist assesses the percentage of tumor necrosis. 90% or greater necrosis indicates a good responder with better prognosis, and the MAP regimen is continued. Less than 90% necrosis indicates a poor responder with worse prognosis, and a regimen change is considered. Neoadjuvant chemotherapy also enables limb-sparing surgery by shrinking the tumor mass and defining a clear resection margin. Case 11. A 13-year-old boy was diagnosed with osteosarcoma of the distal femur following biopsy confirmation. Staging workup with magnetic resonance imaging shows the tumor is well contained within the bone with no neurovascular involvement and no evidence of distant metastases. Neoadjuvant chemotherapy has been completed with a good histologic response, meaning greater than 90% tumor necrosis. The orthopedic oncology team is now planning the definitive surgical intervention. What is the preferred surgical approach in this patient? Option A. Limb-sparing surgery. Option B. High-level amputation. Option C. Simple curettage. Option D. Observation only. The correct answer is Option A. Limb-sparing surgery. Limb-sparing surgery is now feasible in over 80% of pediatric bone tumor cases, revolutionizing treatment outcomes and quality of life. Modern surgical advances include endoprosthetic replacement with biocompatible materials, expandable prostheses for growing children, vascularized bone grafts for biological reconstruction, and 3-dimensional printed custom implants for complex anatomy. Key pediatric considerations include growth preservation through expandable systems, functional limb length maintenance, reduced psychological impact compared to amputation, and enhanced long-term mobility and sports participation. Modern expandable prostheses can accommodate up to 12 centimeters of growth, allowing children to maintain normal limb proportions throughout development. The 5-year implant survival success rate exceeds 95% in pediatric patients. Amputation is reserved only when neurovascular encasement makes limb-sparing surgery oncologically unsafe. Case 12. A 10-year-old boy is diagnosed with Ewing sarcoma of the sacrum following biopsy. Magnetic resonance imaging demonstrates a large tumor mass involving the sacral vertebrae with significant soft tissue extension into the presacral space. The surgical team determines that achieving adequate resection margins without causing permanent neurological deficit is not feasible. He has completed neoadjuvant chemotherapy with a partial response. The multidisciplinary tumor board is now planning local disease control. Which local control modality is most appropriate for this patient? Option A, cryotherapy. Option B, thermal ablation. Option C, radiation therapy. Option D, topical chemotherapy. The correct answer is option C, radiation therapy. Ewing sarcoma is uniquely radiosensitive, making radiation therapy a critical local control strategy, especially for anatomically challenging tumors. Radiation therapy serves three roles: as definitive local control when surgery is not feasible, particularly in pelvic, spinal, and skull-base locations; as post-surgical adjuvant therapy delivered after incomplete resection with positive margins to reduce local recurrence risk; and using proton therapy or intensity-modulated radiation therapy, which are preferred in growing children because they spare surrounding healthy tissue, growth plates, and pelvic organs, and reduce the risk of secondary malignancies. Comparing conventional radiation therapy and proton therapy, dose to healthy tissue is higher with conventional therapy and significantly lower with proton therapy. Growth plate risk is moderate with conventional and minimal with proton therapy. Secondary cancer risk is higher with conventional and reduced with proton therapy. An important clinical pearl: radiation is not routinely used in osteosarcoma due to relative radioresistance. Ewing sarcoma is significantly more radiosensitive. Case 13. A 13-year-old boy was diagnosed with high-grade osteosarcoma of the distal femur following biopsy. He underwent neoadjuvant chemotherapy with the MAP regimen and is now being evaluated for metastatic disease prior to definitive surgery. His chest computed tomography reveals multiple bilateral pulmonary nodules, the largest measuring 12 millimeters. Bone scintigraphy shows no additional skeletal uptake. Which organ is the most common site of distant metastasis in pediatric osteosarcoma? Option A, lungs. Option B, liver. Option C, brain. Option D, spleen. The correct answer is option A, lungs. The lungs are the most common site of hematogenous spread in both osteosarcoma and Ewing sarcoma. Lung metastases occur in 15 to 20% of osteosarcoma patients at diagnosis. Ewing sarcoma shows a similar metastatic potential of approximately 20% at presentation. Pulmonary metastases are the most common distant spread via the hematogenous route. Plain chest X-ray misses small nodules smaller than 5 to 10 millimeters. Chest computed tomography detects nodules as small as 3 to 5 millimeters and is the gold standard for pulmonary staging at diagnosis and follow-up. The prognostic impact is significant. Presence of lung metastases at diagnosis significantly worsens 5-year survival. Patients with localized disease have survival of approximately 65 to 75%. Patients with metastatic disease at diagnosis have survival dropping to approximately 20 to 30%. Complete surgical resection of pulmonary nodules, called metastasectomy, can improve outcomes. Any child diagnosed with osteosarcoma or Ewing sarcoma must undergo chest computed tomography at diagnosis as part of standard staging. Case 14. An 8-year-old boy is referred to a pediatric oncology clinic after being diagnosed with osteosarcoma of the proximal tibia. His family history is significant. His mother was diagnosed with breast cancer at age 30, and his maternal uncle had a brain tumor. Genetic counseling is initiated. Which genetic syndrome is most likely responsible for this family's cancer predisposition and is specifically associated with germline TP53 mutations and increased osteosarcoma risk? Option A, Down syndrome. Option B, Li-Fraumeni syndrome. Option C, Noonan syndrome. Option D, Marfan syndrome. The correct answer is option B, Li-Fraumeni syndrome. Li-Fraumeni syndrome results from a germline TP53 mutation, predisposing affected children to early-onset osteosarcoma, brain tumors, and breast cancer. Among all hereditary syndromes, it carries the highest osteosarcoma risk in the pediatric age group. The TP53 gene encodes a critical tumor suppressor, and its loss removes a key checkpoint against malignant transformation. A summary of key genetic syndromes associated with bone tumors. Li-Fraumeni involves TP53 with risk of early-onset osteosarcoma, brain tumors, and breast cancer. Retinoblastoma involves RB1 with approximately 40% lifetime osteosarcoma risk, especially post-radiation. Rothman-Thompson syndrome involves RECQL4 with osteosarcoma risk, skin rash, and skeletal anomalies. Hereditary multiple exostoses involves extension 1 and extension 2 genes with chondrosarcoma risk and multiple osteochondromas. Werner syndrome involves WRN with osteosarcoma risk and premature aging features. Survivors of pediatric bone tumors with known genetic syndromes require lifelong surveillance, including annual imaging, cardiac screening after doxorubicin, audiometry after cisplatin, and second malignancy monitoring per Children's Oncology Group guidelines. Before we conclude, we want to share an exciting opportunity with you. Join Pediatric Case Review on Patreon, your dedicated learning hub for pediatric medicine. All videos in the community are organized by body system, so you can access every lecture arranged by system and find exactly what you need when you need it. Every slide from every lecture is available as high-quality downloadable photos, so you can read, review, and study at your own pace. You can also reinforce your learning by practicing hundreds of clinical multiple-choice questions across all pediatric topics. To join, simply comment below on this post, and we will message you directly with all the details. Do not miss this opportunity to expand your clinical knowledge. And that concludes today's lecture on pediatric bone tumors. Pediatric bone tumors demand early recognition, accurate diagnosis, and multidisciplinary management. From clinical presentation to treatment and long-term follow-up, every step matters for improving outcomes in our young patients. We covered 15 clinical scenarios spanning nocturnal pain red flags, pathologic fractures, physical examination principles, pathophysiology of osteosarcoma and Ewing sarcoma, imaging algorithms, biopsy principles, neoadjuvant chemotherapy with the MAP regimen, limb-sparing surgery, radiotherapy in Ewing sarcoma, pulmonary metastasis, and genetic predisposition syndromes. Please follow Pediatric Case Review for more evidence-based, case-driven lectures across all pediatric specialties. If you have a question or clinical case to share, drop it in the comments below. We read and respond to every comment. Share this lecture with your colleagues to help fellow pediatric physicians access quality education. Keep learning, keep caring, and see you in the next lecture.